Hey guys, welcome back. The next topic we're studying is diabetic ketoacidosis, and I'll begin this topic by describing an update which has been extensively asked in last 1 year. The update was first time asked in NEET PG 2023, then was asked in the FMG July exam, and then again repeated in the INISET November 2023. So, well, what is the update? It's pretty simple and straightforward. That in management of diabetic ketoacidosis, the bolus dose of insulin that we used to give initially before we used to give insulin drip has been withdrawn. So what we're going to do in our case at the moment is rehydrate the patient using IV fluids. That will reduce the severity of ketonemia. That will take care of even the dehydration component which is coming in because of the vomiting, because of the polyuria part which was present in the case. And then subsequently, I'm going to give IV fluids after 1 hour of IV hydration being started. Let's just see this question, which has been extensively asked in three different exams conducted by three different agencies in our country. A child is brought into the emergency room in an unconscious state after severe vomiting and abdominal pain episodes. In fact, the abdominal pain in diabetic ketoacidosis can sometimes be misdiagnosed as acute pancreatitis because there's going to be severe epigastric pain and there's going to be some amount of rebound tenderness also present. The heart rate of the patient is 100. That's a little on the higher side, but not too much of a concern. BP is 100/60. That's again, I would not take it casually because patient is having vomiting. So I presume that if the vomiting part continues, the BP is going to fall. The workup shows presence of acidosis, blood sugar of 300 milligram, random blood sugar more than 200 in presence of symptoms and signs, or even if there are symptoms and there is a random blood sugar of more than 300, that's sufficient for saying that yes, I'm dealing with diabetes mellitus. And then ketones are present. So if I add up the whole data, there is a acidosis, there are ketones, and there's a elevated blood sugar. So that tells me that the case is of a diabetic ketoacidosis. He said, what should be the best management of the patient? Option A talks about infusion of insulin 0.05 to 0.1 unit per kilogram per dose of insulin after 1 hour of IV fluids. Makes sense, as I said, but let's look at option number B. That is insulin stat followed by infusion. And that is what I was trying to tell you, that the stat bolus dose has currently been withdrawn. So I can strike off option number B from our discussion. Option number C and D talks about subcutaneous insulin. You see, in an emergency scenario, I'll be more comfortable giving intravenous insulin to the patient as compared to subcutaneous insulin. So if it was a mild case, if the pH of the patient was, let me say, closer between 7.30 to 7.35, and the patient was in a peripheral center where inpatient is not available, then before I send him to a tertiary care hospital, I can give a dose of subcutaneous insulin. But if I have all the facilities, then I'll not give subcutaneous, but in an emergency scenarios, I'll be using intravenous. So the correct answer for this one is option number A. It looks very simple at the moment, but only the point to be understood is that in any patient with diabetic ketoacidosis, we need to take care of the acidosis component by giving insulin to the patient because that's going to send sugar inside the muscles. You see, the muscles in our body utilize sugar, but in a diabetic patient, in a setting of absolute insulinopenia, because children with type 1 diabetes are having absolute insulinopenia, so there is no sugar available intracellularly. Sugar is present in the blood, that's okay, but it cannot go inside the muscles in a setting of insulin deficiency. So the muscles need energy. And where does the energy come from? It comes from the burning of fats, which causes generation of ketones. And these ketones are highly acidic. They can damage the blood-brain barrier. And that is why encephalopathy can set in, cerebral edema can set in. And that's in fact the reason for development of death in these patients. In fact, I've highlighted one more MCQ of the previous year exams. That question said, what is the leading cause for death in a diabetic ketoacidosis with respect to a child? I'll be describing diabetic ketoacidosis in adult also. Don't be under an impression that DKA can occur only in type 1, can occur in type 2 also. But specifically in children, if there's a DKA and the child dies, well, one of the important reasons why he's dying is to be answered as cerebral edema. Why cerebral edema? Because metabolic acidosis will damage the blood-brain barrier. The integrity of the blood-brain barrier has been damaged, which results in the cerebral edema component. Yes, there is bound to be dehydration. If I do not give IV fluids to the patient, he can die because of dehydration also. Some of these children could be having infection as well. That's because infection can be a trigger for development of diabetic ketoacidosis. So even sepsis can ensue. So we will anyway be giving antibiotics, antibiotic coverage for this patient if the trigger was something like a pneumonia or a urinary tract infection. But the most important statement that I would like to make for this particular slide is that the bolus dose of insulin has been withdrawn and we can be giving first IV fluids, and after 1 hour of IV fluid administration, what we're gonna do is go ahead with the insulin drip. Well, this is the update that I'm talking about. This update is from the International Society for Pediatric and Adolescent Diabetes. In the 21st edition of Harrison, I would just like to mention the page number. In the 21st edition of Harrison, which has come before this, it still talks about bolus dose of insulin, because this has been used since I have been a student, and I can say since time immemorial. For management of decay, the bolus dose of insulin has been used. So even the current edition of Harrison talks about it, but since there's an update present and in each of these exams, they've said according to the recent updated guidelines. I repeat that again. In the recent exams, they mentioned this fact that according to the recent updated guidelines, which of the following is best management for a case of DKA? And this is the actual guidelines that I'm focusing on at the moment. You see, they can change the question in the forthcoming sessions as well. So what you need to keep for or watch out for, that if he mentions that the same case of diabetic ketoacidosis has gone into shock, if he talks about circulatory failure, and he says what will you be doing in this patient, then you will not answer even IV fluid straight away, because in any patient who's gone into a circulatory failure, there is a coma, there is a decreased level of consciousness, the BP is unrecordable. I need to take care of the airway of the patient, I need to and put in an NG tube, I'll take care of the breathing part, and then would come a normal saline bolus. So if he's going to talk about per se the fluid management for a child of diabetic ketoacidosis who has gone into circulatory failure, if there is mention of the word coma, if he mentions regarding circulatory failure and pulses not being palpable, I would suggest you to answer this as normal saline bolus. On the other hand, if he talks about minimal dehydration and he says that the patient can take orally, and he says what will you do in the patient, then you can use subcutaneous insulin. Remember, in the question that I shared before you, asked in 3 different exams by 3 different authorities, subcutaneous insulin was in the options. But why was it not selected? One, in an emergency scenario, I need to give intravenous insulin. Second, my patient was having acidosis as well as was having coma. So he was fitting into this particular part of the discussion. Let's just go back to the previous slide. I said the patient is having acidosis. The pH was 7.2. The patient was puking. That implies that he's having moderate dehydration. So what are you going to do in this case? You're going to start normal saline. This normal saline would be 10 to 20 ml per kilogram of body weight initially, and then after 1 hour of this, you can see what I was saying, that the continuous insulin infusion has to be started 1 hour after IV fluids. And when you will give IV fluids to this patient, then obviously the ketonemia part will be taken care of. But there's another problem that also needs to be handled, because the patient has been having continuous vomiting. The total body potassium of these patients is reduced, and therefore to manage this hypokalemia, what we will do for the IV fluid, what I will do to the bottle of normal saline is that we will add potassium chloride as well. How much potassium should be added? That would be 40 millimoles per liter at a concentration of 40 millimoles per liter. So the message is, in a patient of diabetic ketoacidosis, if he talks about circulatory failure, then I'm going to talk about airway, breathing, and then a normal saline bolus. Whereas if he talks about moderate dehydration, I'm going to give normal saline to the patient with potassium chloride, and after 1 hour of the same, insulin drip is to be started. If it talks about minimal dehydration, we'll give, and the patient can tolerate orally, then it's okay. I mean, we can give subcutaneous insulin to the patient as well. We'll talk more in detail regarding this algorithm, but this is an updated data which I would just like to share with you, which is totally in contrast to what was present in the previous editions of the app, whether you take a 4.0, 5.0. I mean, in all of them, we have talked about a bolus, but then this is an update that we need to be taking into consideration. A lot of questions that will be asked in this topic would be beginning by saying an unconscious diabetic patient is brought into the emergency room, and then is going to give you pH, bicarbonate values, keto sticks, then plasma beta hydroxybutyrate values, random blood sugar, and plasma osmolarity. Please be clear that keto sticks is not very good to pick up beta hydroxybutyrate. You see, there are 3 ketones in the body. One of the ketones that would be generated in the body of a diabetic ketoacidosis patient is acetone, that is responsible for the fruity odor of the breath. Another one that is generated is acetoacetate. This acetoacetate is the one that is usually picked up by keto sticks. But there's a third, the one which is highly acidic, is beta hydroxybutyrate. And the best way to be sure about diagnosis of diabetic ketoacidosis is beta hydroxybutyrate. Why that is so is because acetoacetate, which is detected by this keto sticks, the dipstick, is converted into acetone. And acetone is the one which is excreted in the breath and gives a fruity odor to the breath of these patients. But the point is, if acetoacetate will be degenerated to produce acetone, then acetoacetate values can be even normal as well. In fact, I said a very peculiar data, but true. In the question they have asked that which ketone body values can be even falsely normal during diabetic ketoacidosis. Acetoacetate values can be falsely normal. Why? Because it is being degraded to produce acetone, which produces a fruity odor in the breath. And because acetoacetate values can be falsely normal, then the bad news is keto sticks may fail to demonstrate that the patient was having ketoacidosis, though there was a genuine ketoacidosis present. So how am I going to be sure? I'm going to run a plasma beta hydroxybutyrate values on the patient, which is the investigational choice for diabetic ketoacidosis. Just like we have discussed, investigational choice for diabetes mellitus is HbA1c. The best way to diagnose diabetic ketoacidosis is plasma beta hydroxybutyrate values. In a large number of questions, when he's going to talk about unconscious, unresponsive diabetic, the pH normally 7.35 to 7.45. It's 7.2, that means it is acidotic status. Normal bicarbonate is in a range of 22 to 26 milliequivalents. Normal bicarbonate values would be 22 to 26 milliequivalents. And in our patient, let me say the value is given to be 15. So it proves that my chap is, or my patient is having metabolic acidosis, and the keto sticks is turning out to be positive, and plasma beta hydroxybutyrate values are elevated, and the blood sugar of the patient is anywhere in the range between 250 to 600 milligram per deciliter. I mean, normally blood sugar of a normal person would be in a range of about less than 100 in a fasting state, but here it is given anywhere between 250 to 600. It's a cause of concern. And if sugar is going to be more, the plasma osmolality will also be more. Normal plasma osmolality is usually in a range of about 275 to 295 milliosmoles, though some books might be saying slightly different values like 280 to 290 as well. But let's say if we take an upper limit of 295, in our case, because blood sugar is elevated, the plasma osmolality in this case would also be given to be slightly elevated, like maybe 310 milliosmoles. So the main message is, because my patient is having a presence of acidosis, because pH is 7.2, there is presence of ketones as well, random blood sugar is elevated, and plasma osmolality is also elevated thanks to the elevated blood sugar, then this would be a relatively easy pickup question for diabetic ketoacidosis. But then keep on listening to the next data, that is say with equivalent amount of care. There's a possibility that they might give you a question in the exam in which the pH of the patient is 7.2, bicarbonate is 15, so there is a metabolic acidosis component present. But he will say that there are ketones turning out to be negative, and plasma beta hydroxybutyrate values are turning out to be normal, and the blood sugar is, let me say, 250. The plasma osmolality is given to be in the normal range. Now, in these circumstances where there is a acidosis, you can see there is a acidosis present, but in spite of the acidosis component being present, the ketones are negative, the plasma beta hydroxybutyrate values are turning out to be normal. That means that cannot be diabetic ketoacidosis. See, you can argue here saying, sir, keto sticks is normal because acetoacetate is getting converted into acetone. But then if it was a genuine case of ketoacidosis caused by diabetes, then at least plasma beta hydroxybutyrate values should be elevated. Here, if they're given to be normal, then you will say that the patient is having lactic acidosis. And to prove this lactic acidosis, which is present, you will have to run another test, that is plasma lactate values, because a lot of these patients can develop an infection and they can end up with the lactic acidosis. Or for that matter of fact, this guy is a known case of diabetes. He's having a diabetic nephropathy, and this diabetic nephropathy was continued by his physician on metformin. You see, in the earlier video I've highlighted, do not give metformin if the EGFR of the patient is less than 30. Now, if the EGFR is reduced, because Metformin can trigger development of lactic acidosis type B as well. So the message is that we should be discontinuing metformin, and this presentation could be iatrogenic induced as well due to drugs, because the physician continued giving metformin to the patient. That is one possibility. Or this lactic acidosis could also be type A, where there's an infection present that can be contributing to this. In fact, details of lactic acidosis are discussed separately with respect to two videos on the arterial blood gas analysis, where I've talked about type A, type B lactic acidosis. But generally speaking, yeah, if drug is contributing to lactic acidosis like metformin or fenformin, then we read it as type B lactic acidosis. If it's going to be circulatory collapse, that would be due to infection like sepsis, then we call it type A lactic acidosis. The main carry-home message is, in any MCQ of an unconscious, unresponsive diabetic brought to the ER, if there is a presence of a acidosis, do not always assume that it's always going to be metabolic acidosis. Check out the reports, because there might be a trick in the question, and the trick in the question could be simple, straightforward fact that the ketones can be missing. Then I cannot call it ketoacidosis, then I'll answer it as lactic acidosis, obviously subject to plasma lactate values. Now let's look at another possibility. And in this question, he'll trick you even further by mentioning that the pH of the patient is, let me say, 7.38. That's okay. I mean, pretty decent, pretty normal. And the value of bicarbonate in the patient is 24 milliequivalent. So far, so good. The pH is normal. The bicarbonate is normal. There are no ketones present. The plasma beta hydroxybutyrate values are also normal. But the sugar of the patient is a astounding 600 to 1200 milligram. I mean, I would say like the blood of this patient is like, fruity in a literal sense, that there's so much of sugar present in the blood. And when you'll attempt this MCQ, you'll be wondering to yourself, what's going on, man? Everything is given normal. pH is normal. Bicarb is normal. Ketones are not there. I mean, normal person doesn't have ketones in the urine. There are no plasma beta hydroxybutyrate elevations present. Or even if, he to trouble you, he might mention slight elevation. That could be due to starvation. But at the same time, the random blood sugar is outrageously high. The plasma osmolality is again deranged between 330 to 380 milliosmoles. So if you get a question which is going to be talking about what I have mentioned as a report at the moment, then we will say the person is having non-ketotic, because there are no ketones, but the blood sugar is ultra high. So what you will answer here, you will answer that your patient is having hyperosmolar coma, and because of this increase in the osmolarity, what's going to happen is that it will again contribute to fluid shifts across the neurons. And fluid shifts across the neurons, I mean, neurons hate rapid fluid shifts, and that contributes to development of altered sensorium and a coma. The reason in this case for the coma is the very substantial increase in plasma osmolality. So the learning point for us is that blood sugar, if it is low, hypoglycemia will obviously contribute to development of seizures and a possible encephalopathy. But if you have a diabetic where blood sugar is ultra high, then hyperosmolar coma can also ensue. The last entry that I'll make before you is again going to look very, very surprising. It will be identical to the report of diabetic ketoacidosis. So look at this once again. We're having a patient. In fact, this would be again a very outrageous report, I would say. So I would like you to listen to this with care and compare this with report of diabetic ketoacidosis, where the pH is 7.2. Acidosis is there, bicarbonate is about 15, and at the same time ketones are also present by ketosticks. Plasma beta hydroxybutyrate values are elevated, but the blood sugar of the patient in this particular case is given to be only, let me say, 200. Now in traditionally in diabetic ketoacidosis, the blood sugar of the patient is bound to be elevated in a range between 250 to 600 most of the time. Here, what we are noticing is that the plasma osmolality is also turning out to be perfectly normal, because blood sugar is not very grossly elevated. Guys, if you get a report like this, then the green data that I have put up here is still a ketoacidosis, but because the blood sugar here is turning out to be not very grossly elevated, so we will answer it as euglycemic ketoacidosis. Now, it looks very surprising to read it, but euglycemic diabetic ketoacidosis can especially be seen in the setting of SGLT2 inhibitors. Even if SGLT2 inhibitors are discontinued, you're aware that SGLT2 inhibitors, what they do is they inhibit sodium glucose link transporter. So there is going to be a setting of glucosuria. This glucosuria can explain the loss of water from the body and triggering of dehydration, and then subsequently the patient can go into acidosis component as well. But the main point is because the sugar is being lost in the urine, that is why the blood sugar of this patient is turning out to be on, I would say, not a very high side, rather is turning out to be very close. Considering a diabetic patient, I mean, 200 is not very high. Or let me say, if I decrease it even further to 150, then you would not call it a very high blood sugar value. That's why the word used is euglycemic diabetic ketoacidosis. This is mainly seen in the setting of SGLT2 inhibitors, even if they have been discontinued even 2 weeks ago. But even then, because the glucosuria component can be present, the continuous loss of sugar will be detrimental to the health of the patient, because if the sugar is lost, water will be lost, and that's going to contribute to dehydration. But this glucosuria component can be responsible for explaining why the sugar in the body of this patient is turning out towards the normal side. So I've discussed a couple of permutation combinations in this particular case. Now let me just, I would say, stretch your imagination a bit more, and I'll just say this verbally. Suppose you get a question in which pH is normal, bicarbonate is normal, ketostix is negative, plasma beta hydroxybutyrate normal values are turning out to be normal, random blood sugar is, let me say, 120, and plasma osmolality is normal. Then I cannot even say euglycemic DKA, because then there are no ketones present, right? If all reports are normal, I'm saying if all reports are normal, and still the patient is unconscious, unresponsive, then what are you going to think of? Then you're going to think in terms of possibility of a neurological event like stroke. I repeat that again. If an unconscious, unresponsive diabetic is brought to the emergency room, if all the reports that I've said here are normal, what I mean here is pH is normal, ketones are gonna be absent, bicarbonate is normal, plasma osmolality is normal, blood sugar is turning out to be 120, 150. But the point is, in the previous scenario, I was saying that blood sugar was towards not very high side, ketones were still present. Now there are no ketones present also, and still the person is unconscious. Then we have to think in terms of a CNS event, and we have to do a non-contrast CT head to rule out the possibility of stroke. I'll just write down this data here because this was a question in the exam, and this has been discussed in the neurology section as well, which is that if an unconscious a diabetic patient is brought to the hospital, first think in terms of metabolic problems. But if case all the metabolic problems are ruled out, the table that we have discussed here is not being satisfied. And if all the reports are normal with respect to whatever I've discussed, what I mean by reports being normal are the datas which are written on the left side of the slide here, pH, bicarb, ketostix, etc. And if all are normal, then you have to think in terms of possibility of stroke. And on a priority basis, you have to be doing a non-contrast CT scan so that you can identify what kind of stroke is present. And lots of time in ischemic stroke reports can be normal as well. In ischemic stroke, there would be a presence of hypodensity, and that hypodensity can take 6 to 12 hours to appear. So initially, if the report turns out to be normal, then no issues, absolutely no issues in those circumstances. I mean, we can still start thrombolysis, and then to prove that the thrombolysis is successful, we can do a CT angiography that can express, or that can prove that the large vessel occlusion has been taken care of. So this I would write as an important table that I would like you to be aware of, including the possibilities that I've written on the extreme right hand side, that is euglycemic diabetic ketoacidosis, and then I've also spoken regarding possibility of stroke if everything else is normal. Let us now focus on pathophysiology of diabetic ketoacidosis. See, diabetic ketoacidosis would be fairly common in patients of type 1 diabetes mellitus where there's an absolute insulin deficiency. In the setting of insulin deficiency, sugar cannot go inside the muscles, and therefore the muscles are starved. In fact, I can say that diabetes is a condition of intracellular starvation, and the condition of a diabetic patient is like that of a man who's sitting in the middle of the sea and there's water everywhere, but not a drop to drink. I mean, a person like if a person is sitting in a boat in middle of a sea, he cannot drink that sea water. Similarly, a diabetic is sitting in a sea of sugar everywhere, but sugar cannot enter in the muscles because insulin is not there. Or like in type 2 diabetes mellitus, I can say a relative insulin deficiency because the receptors are going to be misbehaving. But the point is sugar is there in the body, but it cannot be utilized. That's why it's a condition of intracellular starvation. Now, because of this intracellular starvation, as I said earlier, the body will need energy, and therefore there's going to be burning of fat, subcutaneous fat oxidation occurs, which explains why patients of type 1 diabetes mellitus will always be having weight loss and complete loss of subcutaneous fat. The burning of the fat will generate free fatty acids, and these free fatty acids will then be responsible for generation of ketones, and ketones are acidic, so they cause a progressive decline in the pH of the patient. This decline in the pH is responsible for damage to the blood-brain barrier. The damage to the blood-brain barrier, as I explained earlier, will contribute to cerebral edema, which can contribute to death of the patient. So we can be having like outrageously low pH values in patients on presentation, pH of 6.7, 6.8. Yes, I mean pH of 6.7, outrageously low values can be responsible for this kind of an extreme presentation. And as far as the mortality of diabetic ketoacidosis is concerned, especially if the age group of the patient is greater than 40 years, if a person is older, because as I said, diabetic ketoacidosis can occur in both absolute and relative insulin deficiency, and relative insulin deficiency can be type 2 diabetes mellitus. So if the age of the patient is more than 40 years of age, then the mortality in those circumstances can go beyond 20%. Most of the time when it comes to diabetic ketoacidosis, they can be triggers as well. The triggers that we usually see would be in the form of, in older patients, can be in the form of MI or stroke or COVID-19 pneumonia. So there has to be some intercurrent illness which is responsible. The mortality rate, however, is about 5% in case the age of the patient is less than 40 years of age. Younger patient will be able to handle this relatively better as compared to a relatively older patient because of concomitant comorbidities that could be present in the patient. And more importantly, you see, ketones are acidic, so they're gonna stimulate the respiratory center. This stimulation of the respiratory center is going to explain the acidotic hyperventilation, and therefore we always are going to read about Kussmaul breathing in these patients. Kussmaul sign is always going to deal with the paradoxical rise of the JVP with inspiration that is seen in constrictive pericarditis, restrictive cardiomyopathy, and right-sided congestive heart failure. CRR is the mnemonic for Kussmaul sign. But today we're talking about Kussmaul breathing, that is a acidotic hyperventilation. And in fact, acidotic hyperventilation is one of the indications why these patients should be admitted. What are the triggers for development of diabetic ketoacidosis? Though I mentioned them verbally, I'm just going to put them in the right perspective in the form of a small, quick mnemonic. That would be a couple of I's present here. What I mean by I is, one possibility is person has suffered from an infection. The infection can be in the form of a pneumonia, it can be in the form of a urinary tract infection, it could be COVID-19. In fact, at the time of COVID-19, when the Delta strain was causing mayhem, we were giving large amount of steroids as well. A lot of patients of type 2 diabetes who had not been diagnosed as type 2 diabetes came to know that they're suffering from type 2. Though they were blaming that our steroids are responsible for it, though they were blaming us for saying that, okay, COVID-19 was causing it and that's why I got type 2 diabetes, but they are actually having occult diabetes, which was never identified. And at the time of COVID, because they were admitted and intensive testing was being done, that is when it was found that they were diabetic. And yeah, I mean, when you give a short course of steroids to a person, hypertensive steroids, it's going to spike up the blood sugar value. But then in a person with occult diabetes, the spike would be even much more higher, which will explain that a lot of these patients went into complications like hyperosmolar coma or diabetic ketoacidosis. Though they were picked up on the basis of the lab reports that I mentioned on the previous slide. Then apart from infection, which would be also common in children like pneumonia or UTI, point number two would be valid only for adults in the form of myocardial infarction, or they could be acute ischemic stroke, which is responsible for it. One of the common triggers that we will find in Western countries being responsible for starting diabetic ketoacidosis can be an insulin pump malfunction. You see, the cannula that comes out of the insulin pump or the catheter that comes out of it can be kinked or it can malfunction, so the delivery of insulin can be hampered. Or let me say, from an Indian perspective, we are giving subcutaneous insulin injections to this patient, but there was a marriage in the family, or the parents were busy, or they were traveling, and therefore insulin dosages were mixed. Or another possibility is the child developed some amount of food poisoning, and because he's vomiting, the mother thinks that, okay, because he's not eating, so I should skip dosages of insulin. If you skip doses of insulin, then the absolute insulin deficiency that will occur in a body of type 1 diabetic ketoacidosis will cause mayhem in the form of the data that I've written on the slide, with burning of fat and generation of ketones. So it could be an insulin pump malfunction, or it could be poor compliance with insulin. It is not a deliberate poor compliance with insulin. It is just that the child has not learned at the moment to inject insulin to himself, and the parents were busy because there was an important wedding in the family, or they had to basically travel. Over and above this, drug abuse. Cocaine usage in any kind of surgery will increase the metabolic stress in the body, and that increased metabolic stress. In fact, even infection and infarction, what they're doing is they're upgrading the energy requirement of the body. If you upgrade the energy requirement, you will have more burning of fat in these patients. Sugar can't go inside the muscle. So if you need more energy, where will it come from? If sugar is not available, body will burn more of fats. If you're burning of more fats, there would be more free fatty acids and more levels of ketones being produced, and the pH is gradually going to fall, contributing to immediate manifestations that I'll be describing on the subsequent slide. During this stressful condition, even counter-regulatory hormones will be increased, and these counter-regulatory hormones, what they will also do is another effect from the physiology perspective, that they are gonna decrease ketolysis. In a stressful condition due to metabolic stress on the body, the counter-regulatory hormones are gonna contribute to downgrade of ketolysis. Ketones are being produced in excess, and then they are not going to be degraded. So unless and until I stop this vicious cycle, they are being produced also, they're not getting degraded as well, the person will continue to suffer. And therefore next we'll focus on what are the clinical features, what are the lab reports, and what we need to do to get out of this vicious cycle. The clinical features will revolve around a child with type 1 diabetes mellitus, where the insulin has been stopped due to reasons that I enumerated on the previous slide, whether it was an insulin pump malfunction or was it stopped because the child was sick. But now ketonemia is gonna cause very severe nausea and vomiting. You see, ketones, once they're elevated in the blood, they'll activate the chemoreceptor trigger zone, and therefore the vomiting part can be very severe, associated with severe epigastric pain. This epigastric pain, along with rebound tenderness, can easily be misdiagnosed as pancreatitis. And you will notice that in the lab reports in these patients, you might be having elevated of amylase. Studies have shown that the amylase, which is elevated in patients with diabetic ketoacidosis, is mainly of salivary origin. But as I mentioned, the epigastric pain can be severe enough to be masquerading or can be misdiagnosed by a physician as acute abdomen, and one of the reasons for acute abdomen can be pancreatitis or it can be gastritis as well. Then the reason why the patient is going into coma is mainly because of the increase in the osmolarity of the blood. You see, the reason for the increase in osmolarity is that if you look at the formula for osmolarity, it would be 2 times the value of sodium and potassium plus 1 divided by 18, and then we have to take into consideration blood sugar values as well, divided by 2.8. What I'm trying to say is, guys, the osmolarity of the blood is dependent on sodium, potassium, urea, and sugar. And the sugar will rise once there is an increase in plasma osmolarity. This will cause development of fluid shifts across the brain, and the neurons don't like fluid shifts at all. So even when we treat these patients aggressively, too aggressive treatment again can be counterproductive. Like a lot of these patients are having metabolic acidosis. So I get a query from a lot of doctors, sir, why did you not give metabolic soda bicarbonate for metabolic acidosis? It will bring the pH from outrageously high value of 6.8 towards at least respectable value. But we usually avoid giving soda bicarbonate in these patients. The reason being, again, if we give soda bicarbonate concentrated solution, when it is given, again, soda bicarbonate being a concentrated solution in itself, and the sudden change in pH that it causes can again cause worsening of the encephalopathy component of a patient. So why most patients are brought in an unconscious state is mainly because of the cerebral edema component, and they can be misdiagnosed as having acute abdomen. Osmotic diuresis will also be present due to high blood sugar, and this will explain the polyuria component that is present in these patients. The patient is unconscious, so he'll not be able to tell that he or she wants to pass urine. In fact, one of the warning symptoms for deterioration of the patient would be a age inappropriate incontinency. Adult patient is, or let me say a child, he's 10 years of age, so a 10-year-old child can walk to the washroom by himself, no, but now he's lying in the bed unconscious and he's urinating in the bed, and the mother is saying the bed is soaked with urine, he's urinating again and again, and finally you have to put a condom cath in the child, and the uro bag is getting filled very soon. That's because the sugar is high. It will cause osmotic diuresis, it will remove water from the body, and therefore dehydration component will occur. There's the free water deficit in these patients can be up to 5 liters. The amount of free water loss from these patients on account of polyuria and vomiting can be huge, up to 5 liters, which is 5 fluids need to be given, and which is why initially was saying there can be circulatory failure for which normal saline bolus would be required. If he says pulses are absent, if he says patient has gone into coma, then I will have to give normal saline bolus. If he talks about moderate dehydration, then no need of bolus, but yeah, normal saline needs to be still given to our cases. Encephalopathy is universal to these patients. In any diabetic patient with an unconscious, unresponsive state, if metabolic causes have been ruled out, all the lab reports are turning a bit to normal, then I mentioned CNS events is also to be taken into consideration. Once we have taken care of the symptoms part, let's look at the examination findings. If you bring your face close to the face of these patients, because there is acetone coming out, so the acetate is degraded to acetone, which is exuded in the breath, so fruity odor in the breath can be seen. The vitals will be showing a tachycardia. The BP of these patients will be low, and in some cases it might be even unrecordable as well. So if it is unrecordable, as I said, that's again a cause of concern, and normal saline bolus needs to be given. The respiratory rate of these patients will always be increased. They would be increased in both the depth of breathing as well as the rate of breathing. So it's an acidotic hyperventilation, because ketones on acidic nature will be causing triggering of or activation of the respiratory center, which will explain that actually small breathing is more of a compensatory mechanism in these patients. See, if the ketones in the body are more, then the acidic pH will cause binding to bicarbonate, and bicarbonate values were low, like I was giving you values of 15. Why? Because ketones are binding to bicarbonate and they're consuming the bicarbonate. Now, once there is more of these protons being generated, the stimulation of the respiratory center also sets in, and that's where the small breathing part would come in. Small breathing is a method of compensation where if you tend to breathe out faster, then it will help in more consumption of the protons, because see, the protons are getting bound to bicarbonate, so there would be carbonic acid being produced. That carbonic acid will break down to produce H2O plus carbon dioxide, and the lungs will help in this case. See, there are two organs in the body that are supposed for compensation, that supposedly help in compensation: the lungs of the patient and the kidney of the patient. Now, in case we are having more H2CO3 being generated on excess of protons, then the lungs can help by pushing out that carbon dioxide. If you remove the carbon dioxide, then more H2CO3 will be degraded, and that more H2CO3, why it was being found, was because of excess of hydrogen ions. So that chemical equation that we read, H2O combines with carbon dioxide to produce carbonic acid, then degenerates to produce protons and bicarbonate, is what I'm talking about. And what I just said in the last 30 seconds or so is pure chemistry only. I'll try to explain that once again. There are more protons being generated, so more H2CO3. And if you have more H2CO3, it will break down to produce more of carbon dioxide, and therefore the lungs will try to remove that excess of carbon dioxide by the process of hyperventilation. So it's like a compensatory process that is occurring. In metabolic acidosis, what is the compensation? Respiratory alkalosis, right? If you've not listened to the ABG section, I would request you to, once you finish this video, go to through videos of the ABG part that I've discussed, and there I've explained that compensation always proceeds in a direction opposite to the primary change. If the primary change is metabolic acidosis, the compensation is respiratory alkalosis, and for respiratory alkalosis, you need hyperventilation. That explains why the CO2 in these patients would be reduced. In fact, when you look at the ABG report of these patients, pH will be less, bicarb will be less, understandable. But why is the CO2 being lesser in these patients? That's explained by the compensatory process of respiratory alkalosis and hyperventilation that is ensuing. Let's now look at the workup of these patients. The first test that I'm going to order is the urine ketosticks. The disadvantage or the limitation of urine ketosticks I've already explained to you, that it is good to pick up mainly acetoacetate, but it may not be able to pick up plasma beta hydroxybutyrate, which is why the best way to confirm the diagnosis of diabetic ketoacidosis should be answered as plasma beta hydroxybutyrate levels per se. Like in diabetes mellitus, we say HbA1c. For DK, it is plasma beta hydroxybutyrate values. The random blood sugar of these patients will usually be elevated. Most of the time in the MCQ, the blood sugar would be given anywhere between 250 to 600 milligram. In case you get a question in which only blood sugar is grossly elevated, 800 milligram, 1 gram, outrageously large amount of sugar per deciliter, then we'll think in terms of hyperosmolar coma, as I've explained. Then we'll also check serum electrolytes in these patients. So the total body potassium in these patients is less. One of the reasons why total body potassium is less in these patients is on account of vomiting, which explains why KCl should be added to the bottle of IV fluids. And when you will treat this patient, then insulin will cause potassium to go inside the cells, so it can worsen this hypokalemia component. You see, insulin causes redistribution of potassium. If you give insulin drip to this patient, the hypokalemia component will worsen. So that is why I was initially giving a potassium correction to this patient, in a sense that KCl was being added to the bottle of IV fluid itself. Let us now look at what happens to sodium values in our patient with diabetic ketoacidosis. Well, the sodium values will also be reduced. The logic or the explanation I can explain for that is solvent drag, because see, after all, blood sugar of the patient is elevated, so that sugar will draw in water, and the drawing of water will then result in hyponatremia developing in this patient. The technical term that we will use to describe this hyponatremia component is hypertonic hyponatremia. Why I'm saying hypertonic is because the plasma osmolarity is more, and the hyponatremia component is explained by the solvent drag component. Under no circumstances should you be confusing this with an alternative terminology by the name of hypervolemic hyponatremia. Well, when do you have hypervolemic hyponatremia? Is whenever you are having increase of aldosterone in the body. The basic concepts are, and concept to be understood is, hypertonicity, I mean, English will help you understand osmolarity is more. That's because of elevated blood sugar causing a solvent drag, and therefore sodium values are lesser. But if he says hypervolemic, it means that the hormone that is increased is aldosterone. And what does aldosterone do? It will draw in water, it will draw in salt, and therefore the following event will happen. Whenever aldosterone works, it brings in water as well, it brings in salt as well. You can see I put two arrows in front of water and one in front of salt, to say that water that will come in will be disproportionate to the amount of salt present, which is why the dilution component will come in, and that is why hyponatremia is being mentioned. Well, what are the conditions where we can be getting hypervolemic hyponatremia? Then the best example for this could be ascites, or it can be congestive heart failure, because in congestive heart failure, after all, perfusion of kidney will be less. So aldosterone values will rise, and this aldosterone will then cause more water coming into the system, more salt coming into the system. And I would suggest you to listen to the kidney section also once you're done with this video, because this, you see, diabetes is causing multi-system involvement. So one, I want you to be very comfortable regarding the topic of hyponatremia, because they love to ask about hypovolemic hyponatremia, euvolemic hyponatremia, and hypervolemic hyponatremia. And once you learned hypovolemic, euvolemic, and hypervolemic, then I want you to learn what I just taught, hypertonic hyponatremia. One-liner MCQ, straightforward. Hypertonic hyponatremia, diabetic complication, diabetic ketoacidosis can be seen in hyperosmolar coma as well. On the other hand, if he says hypervolemic, not hypertonic, then it's going to be aldosterone coming in the picture in conditions like congestive heart failure and ascites. So keep a watch for the data that I currently mentioned. And now I'll say a mathematical aspect, which is that for every 100-point elevation of blood sugar, like if sugar in the blood is rising by 100 milligram per deciliter, then it's causing water to come into the system, which will cause this sodium value to fall, and the fall of sodium would be in the range of about 1.6 milliequivalents. So the learning point is, patients of diabetic ketoacidosis or hyperosmolar coma where blood sugar is elevated would be having hyponatremia. For this magnitude of fall of 1.6, I would also like to draw to your attention that sometimes in books you might read that the fall can be up to 3 milliequivalent. I have written 1.6, and even in electrolyte discussion you will hear me saying 100-point increase of sugar will cause sodium to decrease by 3 points. So the query of most people is, sir, should we answer 3 milliequivalent fall or should we answer 1.6? Well, it depends on the magnitude of blood sugar. Higher is the blood sugar, suppose blood sugar is 600, 700, then it will draw more water and the fall can be up to 3. On the other hand, if let me say blood sugar is 250, 350, 400, then the amount of water coming in the system would be relatively lesser, so the fall of sodium would be relatively lesser. So why the disparity is given in books, or why the disparity in two different videos can be present, is because on the magnitude of hyperglycemia present in a patient, higher the sugar, more is the water solvent drag, and more will be the severity of hyponatremia developing. Apart from this, because there's a dehydration component coming in, this will cause KFT to be deranged. So blood urea nitrogen and creatinine values are increased in patients with diabetic ketoacidosis. Then even much more severe dehydration will come in the topic after this, that is hyperosmolar coma, where prerenal AKI can be present. The renal shutdown can even be present. When you will look at the ABG report of this particular case, The pH is obviously gonna be less. PCO2 will also be less because the person is hyperventilating, and bicarbonate will also be less. If all three arrows are going in same direction, it would mean that your patient is having partially compensated. The word is partially, not fully, because pH will normalize and fully compensated. So I'm saying partially compensated metabolic acidosis will be present at this point of time. If CO2 is normal, then I'll say uncompensated. Compensation has not started. But if the guy will start hyperventilation, the PCO2 in the patient will begin to fall. Apart from this, additional test that I'll be doing is anion gap. And in diabetic ketoacidosis, we have is a high anion gap metabolic acidosis, that is HAGMA. HAGMA and NAGMA, high anion gap metabolic acidosis and normal anion gap metabolic acidosis, have been discussed separately in the video of even kidney and electrolytes, and have been discussed in the ABG videos as well. So I would like you to listen to the kidney and electrolytes part after you're done with this. But yeah, anion gap values would be elevated. Normal anion gap is between 6 to 12 millicoulomb, and the formula for an anion gap would be sodium, positive charges in the body, and from that you're gonna be subtracting the negative charges like chloride and bicarbonate. Do not include potassium in the value of calculation of anion gap. I mean, he will deliberately give potassium in the MCQ, and you are supposed to just neglect the potassium value. From sodium, subtract chloride and bicarbonate, and you can work out the anion gap. The reason for the increase in anion gap in this patient would be primarily that the bicarbonate is getting lesser. As a result of it, the mathematical value of anion gap would be substantially increased. Now, because my patient was having acute abdomen as well, and lots of time the severity of this acute abdomen or presentation can mimic like acute pancreatitis, so we will also get serum amylase and lipase values, get them evaluated, and you will notice that these values are elevated. You will find that the increase in amylase in this patient will mainly be that of salivary origin instead of being of pancreatic origin. In some cases, you might have to do even ultrasound abdomen that will turn out to be normal. As far as TLC is concerned, total leukocyte count, it will be most of the time increased because of stress, or they could be intercurrent infection as well. So I will try to look for evidence of intercurrent infection as well. Intercurrent infection commonly seen are either pneumonia or it could be urosepsis. So I'll also be checking the urine routine, urine culture of the patient. I'll also do a chest x-ray. I'm not writing that because evidence of infection has to be anyway done in these patients. If there's presence of any suspicion of infection, even a blood culture will be required. But then aspects like x-ray or urine routine microscopy of blood culture are too routine, so that's why I've not written about them. TLC can be elevated because of stress, or it can be elevated because of infection. From the electrolytes component, the most important thing to be remembered is that at presentation in these patients, potassium will be less. At presentation in these patients, bicarbonate will be less. Bicarbonate less because it is consumed, and potassium because there's gonna be a loss due to vomiting and the dehydration component. And during treatment, you will notice that during treatment, phosphate values will begin to fall and magnesium values will begin to fall. That is because when you treat this patient, sugar will start going inside the cells. When sugar will go inside the cells, then burn energy will be generated in the form of ATP, and for ATP you need phosphate. So phosphate will be consumed, and similarly even magnesium will also be consumed during the process of this energy generation, because it's a coenzyme with respect to the energy generative processes like glycolysis etc. in the cell. So the message is that at presentation we are having a decrease in potassium and bicarbonate, but when we will treat the patient, the electrolyte imbalance that you will get in the patient on treatment, on institutional treatment, is going to be decrease in the phosphate values and decrease in the magnesium values. I'll just write this separately because this will come up even when I discuss the treatment part. The decrease of phosphate and magnesium would be on treatment of a case of diabetic ketoacidosis. That's mainly because of the utilization of these resources in the process of energy generation, because now sugar will be burnt for energy generation. Earlier sugar was not available, and that is where the ketones were having a free run and they were causing a mayhem, and that is why we had to understand or remember regarding all these lab reports. So I will be confirming now my diagnosis of diabetic ketoacidosis on the basis of the following three things. The glucose would be given to be elevated. The beta hydroxybutyrate values will also be given to be elevated in case he wants to give me this beta hydroxybutyrate values. If he chooses not to, then he will mention simply regarding keto sticks test being done in a patient, and that is more than sufficient in most of the cases. And in a lot of MCQs, I mean, this beta hydroxybutyrate value will not be given. So if we have elevated glucose, keto stick slash beta hydroxybutyrate elevation, and a fall in pH, the three things together is diabetic ketoacidosis. When will you admit the patient? In case on admission the pH is turning out to be less than 7 on a arterial blood gas analysis, you are having labored breathing or labored respiration. Most of these patients, when they come to us with severe metabolic acidosis, you can pick up that acidotic hyperventilation very, very easily, and the person will not be in his senses when you call him out by his name, or even if he's opening his eyes to name, he'll not be able to tell you whether he's at home or whether he's in hospital. So there is going to be an impaired level of either arousal, or there would be impaired level of awareness of his surroundings. I mean, he might be partially arousable, that's okay, but then he will not be able to or will not be aware of his surroundings. You have to get electrolytes evaluated, that is sodium, potassium, magnesium and phosphate, which are gonna be decreasing when you treat this chap. You will take care of the chloride component and bicarbonate. I mean, these are the reports that you need to check. What's going to happen to sodium? It's going to be less due to solvent drag. Potassium, that's going to be less because of the losses due to vomiting. And as far as bicarbonate is concerned, it will again be less on per se, the consumption of the bicarbonate by the ketones. And when you will be giving normal saline to your patient, normal saline means more chloride will come in. And whenever you give normal saline to your patient, you are giving chloride administration. And when you give chloride to the patient, then the chloride values in the body will begin to rise because you're giving substantial amount of normal saline. Now, if there are more negative charges in the body, if there are more negative charges in the blood, then to maintain electroneutrality, the bicarbonate will start going inside the cells. And because of this bicarbonate going inside the cells, I can say normal saline administration can cause development of hyperchloremic acidosis. See, you always would have read this statement that normal saline administration in large amount has a side effect, and the side effect of this is hyperchloremic acidosis. Well, what will you do to prevent this from happening? I'll just explain to you, but I just want to bring to your notice that if normal saline is given in large amounts, what does it cause? It causes acidosis. And what was the presentation of our case? Again, an acidosis. So the query of a lot of people is, sir, you are giving a fluid that is causing an acidosis. I'm saying this is going to be when excess of it is given. Normal saline will be taking care of a replenishment to the sodium and the water in the body, and the dehydration part would be corrected. But if we give normal saline in excess, that is when in fact, I'll use a different color to just highlight the fact that I'm talking about normal saline excess at the moment. Normal saline excess means more negative charges in the blood. To maintain electroneutrality, alphabet EN here stands for electroneutrality. To maintain the electroneutrality in the body, the bicarbonate then starts going inside the cells, and if bicarbonate values in the blood will fall, because bicarbonate, if it will go inside the cell, the blood value of bicarbonate will fall. That will explain why normal saline excess causes hyperchloremic acidosis. And to keep a watch on the same, this is why chloride is being done in this patient. I mean, if I find that the chloride is disproportionately rising, then I will change the IV fluid. I will not be using 0.9% saline, then I will start giving 0.45% normal saline. I repeat my statement again. First, I taught you normal saline in excess can cause hyperchloremic acidosis. Second concept I taught you was that if I find that there is a disproportionate rise of this chloride, and if it starts rising on my treatment, I know that the bicarbonate values will be falling disproportionately and acidosis will ensue or person can worsen also. So what I will do is I will slow down my fluid administration in a sense that the delivery of chloride will be slowed by changing the fluid from normal saline to 0.45% normal saline. So chloride is being talked about at the moment because too much of chloride can be again troublesome. And as I explained, on treatment, these two values would be falling on treatment per se. I mean, magnesium values and phosphate values will be becoming lesser with respect to treatment. They can be slightly low at presentation as well, primarily because of the starvation component. But the main reason why hypomagnesemia, hypophosphatemia can be seen in patients or DK is mainly with respect to the treatment part. I'll assess the ABG on the basis of which the decision for admission has been done, and KFT of the patient also needs to be checked. So one more test apart from electrolyte that needs to be checked is the KFT and the ABG data, about which I have already talked about, with all the three arrows going in same direction. Now, there are a couple of permutation combinations that you should be aware of with respect to when would you say that ketoacidosis is mild or whether it is moderate or severe. Then for mild variety, the pH will be between 7.25 to 7.30, and then you need to just decrease it by 0.25 values again. So between 7 to 7.24 is moderate, anything less than 7 is severe, and that is when I was admitting my patient. Similarly, as far as the blood values of beta hydroxybutyrate are concerned, between 3 to 4 and the pH values corroborating for the horizontal data, that would be mild variety of diabetic ketoacidosis. If we are having 4 to 8 millimoles per liter, and that is when it's corroborating with the horizontal data of pH of 7 to 7.24, I'll say moderate. And in case the values are shooting beyond 8, so what you can remember is just the number 78 per se. For the severe variety of diabetic ketoacidosis, what I mean by 78 is the pH would be less than 7 and the beta hydroxybutyrate values would be going beyond 8 millicoulombs. In fact, in MCQs, what he will do is that instead of talking about beta hydroxybutyrate values, he'll start talking about bicarbonate value. As I was just tempted to say that. You see, bicarbonate obviously will be lesser in a patient, but how do you determine severity? One way of determining severity is the magnitude of fall of bicarbonate. Another way is to pick up the main agent. I mean, this is the agent which is causing the fall in the value of the bicarbonate. In lot of questions, you will notice that beta hydroxybutyrate values may not be given. That is when you will select bicarbonate magnitude fall. I mean, the magnitude of fall of bicarbonate, whether it falls by 5 points or 10 points or 15 points, let me say. I mean, that's going to tell me regarding the severity of diabetic ketoacidosis, and the reason for that fall of bicarbonate is the villain which is given on this slide. In some questions, however, like we discussed regarding the, in fact, I'll just go back to the initial slide once again, which was right in the starting of this video. The International Society for Pediatric and Adolescent Diabetes mentions that in a child, you have to take into consideration possibility of minimal dehydration, moderate dehydration, or the patient can be in circulatory failure. So let's just focus on a couple of core points here, and that would make us more comfortable, because I'll be writing down the data here, so you can practice with me here. I mean, what are you gonna do in case he talks about patient who's into circulatory failure? Now, if the patient is in circulatory failure, then my topmost priority will be to give normal saline bolus to this patient to get the pulses back. But from an MCQ perspective, I'll first answer take care of the airway and breathing. I'll be instructing my nurse to put in a NG tube, and once I've done that, I have myself secured a IV line using 0.9% normal saline, which is the fluid of choice for diabetic ketoacidosis. I will be giving a bolus. Now, on giving this bolus, I'll be again checking the femoral pulse of the patient, and most of the time I might have to give a 20 ml per kg bolus again as well. My objective is to repeat giving these boluses till the pulses in this patient become palpable, because my objective is, after all, to get this patient out of this mess of circulatory failure. The diametrically opposite aspect of this would be minimal dehydration, where a patient can tolerate oral fluid. And in case, there is no problem with oral intake, then we can be giving subcutaneous insulin. In fact, the final objective of ours is to get this patient back to subcutaneous insulin, and currently sick, so I can continue with oral fluids and subcutaneous insulin. As far as the moderate dehydration part is concerned, when will I say moderate dehydration and the patient is having protracted vomiting, is acidotic, but there is no circulatory failure in this case. This was the case that was actually given in the exam. So anyway, we need to give normal saline 0.9% to this patient. Initially, the fluid that would be given would be 10 to 20 ml per kilogram of body weight. And we need to rehydrate this patient, because see, the ketonemia part needs to be diluted, because ketones are causing triggering of the chemoreceptor trigger zone, causing vomiting, causing damage to the blood-brain barrier. So I need to produce a dilutional effect in this particular case. Obviously, the free water deficit in this case can be very substantial, up to 5 liters. So I will not be correcting all the fluid deficit in the patient. I'll get the patient out of severe dehydration, that is okay. I'll get the pulses back to normal, but the free water deficit in this patient can be corrected over 24 to 48 hours. So the main thing is we do it slow and steady, but it's a steady improvement or progression that we need to do. We will also add potassium chloride. Why it is important to add potassium chloride is because total body potassium in these patients is reduced. The concentration of potassium that can be given safely via peripheral line would be added to the bottle of normal saline 40 millimoles per liter after 1 hour. That's the point. That's to be remembered from the exam perspective, that we don't rush into a insulin drip right away. We first give normal saline correction to this patient to correct the dehydration component, and then subsequent, obviously it will not correct within 1 hour, but at least it will reduce the ketonemia part as I explained, and the potential time bomb that this person is setting on will substantially be reduced. And now we will be putting this patient on an insulin drip, because they've asked even the dosages as well, or you can just have a look at the passing reference with respect to the values that I'll be writing in this case. So we'll be giving regular insulin. See, all insulins can be given subcutaneously, but which insulin can be given intravenously to the patient is regular insulin. So a short acting insulin would be given in this case. This would be 0.05 to zero point 0.1 unit per kg per hour. This would be given in the form of an infusion. And important thing that is to be taken into consideration at this moment is that the moment you start giving insulin drip, potassium will start going inside the cells, because I know potassium will start going inside the cells. Therefore, I also need to take care and factor in that movement. So, important statement that I want you to now remember is that do not give this insulin drip if the potassium values are less than 3.3. I'll mention the theory part on my subsequent slide. I'm just saying it verbally at the moment. This was asked in FMG exam, in fact. Then when would you hold this insulin drip? You want to hold this insulin drip when the serum potassium is less than 3.3. Let the KCl bottle, which is added to the bottle of IV fluid, run for a little longer duration. Let the potassium values go to a safer value of 3.5, 3.6. See, hypokalemia can cause diaphragmatic paralysis. So I don't want to take a chance where potassium was less than 3.3. I give insulin drip, it becomes even more lesser. And that's when I start having muscle weakness developing in this patient, or diaphragmatic paralysis developing. Because of diaphragmatic paralysis, then he will not be able to hyperventilate. He needs that lung muscles to hyperventilate and excrete carbon dioxide, because excretion of carbon dioxide will cause consumption of those protons. Remember that chemistry cycle that I was talking about, that H2CO3 is being formed in excess amount. So I want that H2CO3 to be consumed. And with low potassium, the problem is the lungs will not support that washout of carbon dioxide. So compensation processes will stop. So that's why the link is insulin causes hypokalemia, hypokalemia causes diaphragmatic paralysis, and diaphragmatic paralysis, or even if diaphragmatic paralysis looks far-fetched to you, at least it will cause diaphragmatic weakness. So I hope you'll agree to my point that diaphragmatic weakness in this particular case will hamper the compensatory processes that are occurring. That is why I'm so paranoid about ensuring that I do not give insulin drip to this patient till potassium values are in a range of 3 or more, and any value less than 3.3, you have to delay, not stop, but delay administration of this insulin drip. Then this time factor, this time factor between the IV fluid and then the insulin drip will increase till potassium values go to respectable values. So now let's handle a couple of one-liners based on the data that we have learned. Some additional points will be added here as well. When you go in for management of diabetic ketoacidosis in the lines that I mentioned, then usually the sugar will begin to fall. So he can ask you that what will be the magnitude of fall of sugar. Then most of the time with the protocol that we have discussed, normal saline followed by an insulin drip, the fall of sugar that we usually encounter will be about 50 to 100 milligrams per hour. Then whenever the plasma glucose will reach between a range of 200 to 250, when patient came the value was between 250 to 600. Whenever the glucose value will reach in this range between 200 to 250, you will change the IV fluid. What is the IV fluid that is now to be given to the patient is 5% dextrose, which is to be given along with half normal saline, that is 0.45% saline. So do remember this statement, that if they give you a question in which in diabetic ketoacidosis on management the sugar values drop down to between 200 to 250, then I don't want them to fall even further, because the dramatic fall of sugar again can contribute to not only a neuroglycopenia, but apart from this, the rapid fluid shifts is what I'm worried about. So that's why what we will do is give a bit of sugar, 5% dextrose with N/2 saline. The insulin drip is continuing at this particular moment. So when I say 5% dextrose, the query is, sir, will the sugar not rise? No, we are giving that insulin drip at the moment. Start start insulin as soon as the patient is eating. When I say this, this is about the subcutaneous insulin. So wherever possible, once ever the patient will start eating, we will migrate to using rapid acting insulin with respect to every meal, and we'll give a basal cover by using glargine as well. The basal bolus regimen is discussed in the previous video, so I'll not get into that again. But the objective is subcutaneous insulin is to be started as soon as the patient starts eating. As far as the leading cause of death in a child is concerned, in OPKI it is given as the leading cause of death in diabetic ketoacidosis is cerebral edema. And after cerebral edema, he does talk about another reason for death that can be dehydration, but that would happen only in those situations where the IV fluid correction has not been given. If he says what is the leading cause for death with respect to adult, well, a lot of these patients with type 1 diabetes are kids, but then the message is that DKA can occur even in type 2 diabetes as well. And one of the reasons why these patients can die is due to acute respiratory distress syndrome. A lot of these patients are already having kidney damage. Type 2 diabetes might have already caused a nephropathy. And if you cause a significant volume depletion, that significant volume depletion can trigger acute kidney injury, so renal failure can set in. And apart from this, the dehydration component can even bring about a bowel infarction. So there are multiple reasons why these patients can die, but then one of the important ones is acute respiratory distress syndrome. The first line fluid for management of DKA is normal saline. The treatment of choice for this condition is insulin drip. And when you are giving this insulin drip to this patient, because hypokalemia can set in, so as an additional aspect, what I'm saying is add KCl to the bottle of normal saline. That's to take care of the hypokalemia component that can occur. And hold, the word is hold insulin drip. If you are noticing that the serum potassium of this patient is less than 3.3. At this junction, the query a lot of people is, why did you not give ringer lactate to the patient? Yeah, I can give ringer lactate also. That's not the problem. But ringer lactate has very limited amount of potassium. So that will not be sufficient to take care of the losses, and that will even not be sufficient to take care of the effect of insulin. So if hypokalemia would still be present in spite of giving ringer lactate, then I will use it as a backup and not as the initial fluid. See, the point is I wanna prevent values going to lower limit of whatever I have written here, because then the muscle weakness ensues and the compensatory mechanisms can be affected. Apart from this, can you give subcutaneous insulin in mild diabetic ketoacidosis? Then yes, I showed you the recent updated guidelines in the flowchart, and I'll just bring that slide to your notice. In fact, this is the replication of the original slide that we discussed. So yep, you can be using subcutaneous. And as far as bolus insulin and soda bicarbonate are concerned, then they are not recommended anymore. The bolus insulin has been discontinued recently, and as far as soda bicarbonate, the usage of this is discouraged, because soda bicarbonate by itself is a very concentrated solution that can worsen the fluid shifts across the brain, and the rapid changes of pH can again cause a cardiac deceleration. So sudden change of pH can even cause myocardial excitability, and it can trigger arrhythmias as well. So we will not be comfortable giving soda bicarbonate for this patient. These are a couple of one-liners with respect to diabetic ketoacidosis that I have discussed. And the most peculiar one in this one-liners that I've discussed for DKA that you guys should be remembering is that once you start treating a patient in the sugar value, which was initially 350, 400, 450, once it goes between 200 to 250, then what you're supposed to do is change the fluid to 5% dextrose and half normal saline. I've also taught you that if normal saline being given to a patient is triggering hyperchloremic acidosis, you can switch over to half normal saline. Then no need of 5% dextrose, but if sugar is falling, then yes, 5% dextrose needs to be added to half normal saline. Next up is hyperglycemic hyperosmolar coma. In contrast to type 1 diabetes mellitus, where he will say that it is a known case of type 1 diabetes, here he'll talk about a patient who is not diagnosed with diabetes mellitus at the moment. So I'm writing occult diabetes mellitus. He will be diagnosed as a diabetic in the hospital, but this middle-aged patient at the moment is not aware that he's a diabetic. Like the same that happened in COVID, but they diabetics suffered from COVID. They went to hospital, they were put on steroids, and that is when they were found that the rise of blood sugar was disproportionately high in their body, and they started even having features of ketoacidosis, and that's when, or having hyperosmolar coma, and that is when we were finding that those patients who were deteriorating and having an encephalopathy were actually pre-existing diabetics who worsened due to administration of steroids. Now, this middle-aged patient would be having a trigger. The trigger will be uniform. I mean, it can be diabetes mellitus, it can be stroke, it can be pneumonia, it can be urosepsis. So, the traditional triggers will remain the same. And the importance of knowing these triggers is only that the trigger will cause an increase in energy requirement in the body. And the energy requirement is, in this particular case, will cause a problem because type 2 diabetes has a relative insulin deficiency. In type 1 diabetes, I was saying absolute insulin deficiency, I was saying insulinopenia. In this condition, insulin is elevated but is not able to act because the receptor is malfunctioning, and as a result of it, the sugar in the body of this patient will keep on rising. The presentation of hyperglycemic hyperosmolar coma is insidious onset. Unlike in diabetic ketoacidosis, which is fast onset and the patient deteriorates in a matter of a day or days, in this particular case, it would be insidious onset gradual deterioration to the level that the person will then develop pre-renal variety of, because the rising of sugar will then draw in water. It can even cause osmotic diuresis. So the ongoing losses will trigger dehydration in this chap. The input will not be corresponding to the output, and therefore the dehydration component can be severe enough for this person to go into pre-renal AKI. They can be development of azotemia, and that is when encephalopathy component or a decrease in the level of consciousness of this patient will occur. The message is, for type 1 diabetes mellitus or for MCQ diabetic ketoacidosis, he will talk about a child who missed the insulin shots due to various reasons, and then now in a matter of I would say days, he's sick. And in this case, the diabetic patient, gradual decrease in the level of consciousness, like over the past couple of days he has been sleeping excessively, and family members thought that okay, I mean, a diabetic, maybe he's a little tired, or they did not notice that the excessive sleepiness is having a medical reason. They just thought that okay, like non-medical people say like this, weather was changing and therefore it's becoming colder and therefore he was sleeping more. So his wife is saying, like, she's trying to rationalize that I thought that he's a little more sleepy because he's more stressed out at work or some family problem, or so weather is changing. They'll try to rationalize the part that they missed the fact that there was a gradual onset deterioration to the level that then he will stop. Like for previous 24 hours, this guy is not opening his eyes, he's not recognizing his family members, and that is when they brought him to your hospital. So when you will be doing workup of this patient, that is when the shocking thing will be the absolutely grossly elevated blood sugar value that would be in the range of 600 to 1200 milligram per deciliter. Because the person has gone into encephalopathy, initially I thought I should do a CT head as well. Stroke can be a trigger for it. So you could be having trigger, stroke and hyperosmolar coma occurring together as well. Or there's another possibility that even if he will develop a ischemic stroke, the CT scan, if done early, might even be normal in this patient. So CT scan will not give me too much of evidence if it is going to be ischemic stroke. If it is hemorrhagic stroke, then obviously the evidence would come up. But the main crux of this discussion is, if you have a grossly elevated blood sugar, you will look at the ABG values. The pH in this case is going to be normal. The PCO2 of this patient will be normal. The bicarbonate value of this patient will be normal. So the report of ABG is normal. There is no acidosis. The only thing that is present is grossly deranged values of blood sugar. If I am going to check out plasma beta hydroxybutyrate values of these patients, then most of the time it will again be normal. Though if the person is going into a starvation mode because he has been sleeping for last 2 to 3 days, he is not waking up and has not eaten anything, then there is a possibility that slight elevations of beta hydroxybutyrate, not of that values of 8 millimoles that I was describing for DKA, but slight elevations can be present. The reason for this slight elevation can be due to possibility of starvation in this patient. The query of most doctors then is that, sir, if you are saying ketones are elevated in the blood, then why are you not saying that this is ketoacidosis? I mean, the ABG report can be falsely normal also. There could be error in the ABG report. Well, to be sure that, okay, is it, now talking about if there is an elevation of beta hydroxybutyrate. If there's an elevation of plasma beta hydroxybutyrate, another test that would come in handy for diagnosis of this condition is plasma osmolality, because in these patients the plasma osmolality would be something in the range between 330 to 380 milliosmoles. The point is, guys, that plasma osmolality showing a gross elevation is the highlight of why we are calling the disease as a hyperosmolar coma. We calling it hyperglycemic hyperosmolar coma, or in some books this would be written as non-ketotic hyperosmolar coma. In this MCQ, there will be no mention of any nausea, vomiting, abdominal pain. There would be no mention with respect to any small breathing. There would be no mention with respect to any epigastric pain and rebound tenderness present. So when you read the question with respect to a middle-aged man who has been excessively not feeling well, irritable for past 1 week and has been sleeping excessively for past 2 to 3 days, and now his urine output is substantially reduced and he's gone into a encephalopathy, will think in terms of hyperosmolar coma based on the lab reports that I have discussed. Now, coming to the treatment of hyperosmolar coma, the first line treatment would still remain the same. The fluid of choice would still remain the same, that is normal saline. The amount of free water deficit in this condition can be fairly substantial, even much more higher as compared to DKA, where I was saying free water deficit can be up to 5 liters, and I'm saying free water deficit can be up to 10 liters over up to 48 hours. In these patients, because of the dehydration component, the sodium values can be slightly elevated. So suppose in a question in hyperosmolar coma, because there was substantial dehydration at presentation, the sodium was grossly elevated, then he might say that what is the fluid that would be recommended in a setting of hypernatremia. I'll not give normal saline, then I can be using 0.45% saline. The last time I was talking about 0.45% saline was when there was possibility of hyperchloremic acidosis. At that time, I added 5% dextrose if the blood sugar was falling towards euglycemic range in a diabetic on treatment perspective. But now I have mentioned that because of dehydration component, if sodium is elevated, again 0.45% normal saline would be required. As far as the administration of insulin is concerned, we can be giving again insulin drip, and the insulin drip will again cause the sugar to go inside the muscles, and the sugar was grossly elevated 800, so downgrades to 700, 600, 500, and gradually the patient will tend to improve. The insulin drip will be continued till the patient regains consciousness and is in a status where he begins to eat. And once he will begin to eat, we'll switch this patient over to subcutaneous insulin. That's going to be a basal bolus regimen. So these are the details that I would like you to remember for this topic. Thank you so much for your patience in hearing me out. And yep, keep hammering, keep the pressure on. And I can say, I mean, you've done the right thing by listening to this video, because in endocrinology, one question that will always come is diabetic ketoacidosis. So if you ask me like 1 month before the exam in endocrine topic, what should I be listening to? Then even if you don't listen to a remaining whole data, doesn't matter. But I want you to listen to the decay part and then the hypersmolar coma part that I've discussed before you. And anyway, the overall, the most important slide, which I can say is one, obviously the update. And second is this table of various permutation combinations that I mentioned is the crux of this particular topic.